Good morning, everybody. My name is Larry Hoffheimer, and I am the founding chair of the Macular Degeneration Association. I began my journey with Macular Degeneration Association having witnessed my mother losing her entire central vision to wet AMD more than 20 years ago. There was little treatment then, and as a result, uh, little less was known and little could be done. That's all changed, as you hear. The Macular Degeneration Association is focused on educating patients primarily about macular degeneration, what are the causes, what are the treatments, and what's in the future. Please visit our website, which is macular hope, one word, .org for future seminars. We will be conducting those on a regular basis throughout the year. I also want to thank our sponsors, Regeneron Pharmaceutical, Novartis Pharmaceuticals, and Notovision for helping to support these virtual patient conferences. I want to talk, the Macular Degeneration Association receives funds for these events primarily through voluntary charitable contributions. Please visit our website. You'll learn more about the Macular Degeneration Association and our activities. Our first speaker is a very interesting gentleman. His name is Stephen Ferrucci. He is an optometrist and a graduate of the New England College of Optometry uh, in in geriatric optometry at Sepulveda VA Hospital in Sepulveda, California. He's currently chief optometric of optometry at the Sepulveda VA Ambulatory Care Center. He's also the residency director at his location. His emphasis includes therapeutic treatments of glaucoma, cataracts, diabetic retinopathy, and he's also published several articles in optometric journals, including the New England Journal of Optometry, Optometry and Vision Science, and Optometry, the Journal of the American Optometric Association. He's an active member of the AOA, as well as a fellow in both the AOA and Optometric Retinal Society. And he's going to talk today about genetics and its role in our eye disease history. And it's now my distinct pleasure to introduce you to Dr. Stephen Ferrucci. Dr. Ferrucci.
Thank you, Larry. Thank you for that kind introduction. And some of the stuff that Larry had mentioned in his introduction, we're going to talk about today. Some of the new treatments and some things that we can do as patients to help prevent our macular degeneration from getting worse. So as Larry mentioned, my name is Steve Ferrucci. I'm the chief of optometry at the Sepulveda VA, which is a large VA hospital out here in Los Angeles, California. I'm also a professor at the Southern California College of Optometry as well. So I want to talk about genetics and AMD and how genetics plays a role in macular degeneration. Disclosures, there's a couple different companies I work with in various capacities, some of which I will mention in my presentation today, but I hope to do so in a fair and balanced way. So just by way of introduction, AMD, age-related macular degeneration, is a leading cause of vision loss in Americans over the age of 60, and advanced macular degeneration is a leading cause of vision loss and irreversible blindness worldwide in those over the age of 50. It's estimated that somewhere around 11 million Americans have some level of macular degeneration, and those numbers are expected to double by the year 2050. And those two, AMD is more common than glaucoma and diabetic retinopathy, which are two other things as optometrists and eye care professionals, we spend a lot of our time diagnosis and treating. But you can see it's way more common than glaucoma as well as diabetic retinopathy combined. Essentially, there are two separate forms of macular degeneration. There's the dry form and the wet form. The dry form is characterized by geographic atrophy, drusen, and RPE hyperplasia. These are changes in the macula, the center portion of your retina. And this is the most common form. It accounts for about 90% of all of those patients with macular degeneration. There's also the wet form, also called neovascular form. This is characterized by subretinal blood, hard exudates, and or subretinal fluid from choroidal neovascular membranes. So in the wet form, essentially, the blood vessels start to become damaged, and then these blood vessels can actually start to leak blood and other fluids into your eye, and this can lead to very poor vision, unfortunately, sometimes very rapidly. The wet form only accounts for about 10% of macular degeneration, yet accounts for 90% of all those that have legal blindness from macular degeneration. So while not as common, it's much more severe and accounts for patients with more severe vision loss. Signs and symptoms of macular degeneration, AMD affects the macula, the area responsible for the fine or central vision. So when you're looking at something, you really focus with your macula at what you're looking at so that you can see it as good as possible. Early symptoms can include gradual or sudden change in central vision. Straight lines may appear wavy or distorted, and the patient can have difficulty reading or seeing details, especially in low light levels. But one of the unfortunate things is that many patients with early macular degeneration may be asymptomatic and not even realize they have the disease until sometimes it becomes very advanced. So that's why it's really important to get your eyes checked on a routine basis. Patients with early macular degeneration, like I said, may actually be asymptomatic. So they really recommend that patients over the age of 60 and those at risk for macular degeneration should have an annual eye exam focused towards making sure that there's no evidence of early macular degeneration. Some of the things that might be included in a routine eye exam or an eye exam tailored towards looking for macular degeneration would be the measurement of the visual acuity. Obviously, that's when they put up the chart and they have you read the chart. That gives them an idea of the level of your vision. A dilated retinal exam, a dilated eye exam, where they put some drops in your eyes to dilate the eyes, and that allows us to look more extensively in the back of the eye and look for any signs of macular degeneration. There's also an older test called an Amsler grid, and you can see on the picture there, it has some lines going up and down and side to side. This is a way to measure your macular function and to look if there's any metamorphopsia or any fluids in your macula that may be starting to cause some damage. We might hear later from someone else, Dr. Blemker, that the AMSA grid is now sort of being replaced by some newer ways that we have to look for macular function in these patients as well. And then there's some additional tests that are sometimes done depending on where the other examinations or other part of the examinations bring us. There's something called an OCT. It's a machine that kind of takes pictures of the inside of the eye from a kind of a cross view to look for any signs of damage in the retina. There's a test called the fluorescein angiography that we sometimes do, as well as just general photos. And photos can sometimes be helpful to monitor a patient's state over a certain period of time. As I mentioned, studies show that many patients with macular degeneration can go undetected and will initially present with vision loss. And there was one study that said that almost 80% of patients presented with neovascular AMD and vision of 20/50 or worse on their initial presentation. So, one of the things that, again, is important as an eye care professional is to try to get our patients in, especially our older patients, or patients with a family history of macular degeneration, and check and make sure that they do or don't have any signs of macular degeneration. And the sooner we can find macular degeneration, the sooner we can institute some changes to hopefully prevent it from getting worse. And we'll talk about some of those changes in a little bit. Oops, sorry about that. I clicked it twice. Risk factors for macular degeneration. Age is one of the biggest risk factors for macular degeneration. As we get older, we're more likely to get macular degeneration. It's sort of as simple as that. And unfortunately, there's not much we can do about that. But it's one of the biggest risk factors. Race is also a risk factor. Studies tell us that Caucasian patients like myself, also patients with lighter skin, lighter eyes, lighter hair, that sort of thing, are more likely to get macular degeneration than are African Americans, Hispanic Americans, and patients with darker pigment in general. Smoking has been found in study after study to be the #1 modifiable risk factor for macular degeneration. So one of the first things I do if I find macular degeneration in one of my patients, or if I have a patient who's concerned about macular degeneration or has a family history of macular degeneration, one of the first things I do is I counsel them about the dangers, of smoking and how it's the #1 modifiable risk factor for macular degeneration. UV exposure. Studies, especially studies in the past, have showed us that UV exposure can also lead to macular degeneration as well. That's a little bit difficult because often by the time a patient is diagnosed with macular degeneration, they may be, somewhat older in their 70s, and they've already had 70 years of UV damage. So where it's important to discuss UV exposure with the older patients, it's really important in our younger patients that they protect themselves from UV, wear sunglasses when outside and all that sort of thing when they're younger, because that's when the damage is probably the worst. Poor diet, not eating healthy is also a big risk factor as well. Obesity, and we'll talk about some of these things. I'll share some studies with you a little bit later that highlight some of these. And then family history and genetics. And, Larry had mentioned that I believe he said his mom, had macular degeneration, and, these sorts of things like macular degeneration are passed down through families. So because of that, years ago, about more than a decade ago now, it's probably closer to 15 years now, I believe, some researchers started to look at, well, if we know it runs in families, right, perhaps there's a genetic component to it. So that's what we're going to talk about in a little bit. But I just wanted to give you a little background before we did. So as I mentioned, because of the fact that we see that macular degeneration runs in families, these researchers started to look at it. Okay, is there a genetic component to it? Can we find stuff in people's DNA and in their genes that makes them more likely to get macular degeneration? And they've been studying this for years and years. I think the first study that I'm familiar with that looked at that genetics in AMD, I believe it came out in 1994. So almost 20 years ago now, right? 18 years ago or something like 17, whatever. Math was never my thing, quite frankly. But what they know after looking at all these studies, that AMD is in fact a genetic disease with known genetic markers accounting for at least 70% of a patient's risk. And the other 30% is environmental or lifestyle. And we discussed those risk factors a little bit already, right? Risk factors, non-modifiable age, race, and gender. Women tend to get macular degeneration more than men. Of course, women tend to live a little bit older than men, so the numbers get a little bit skewed there. Modifiable risk factors, smoking, increased body mass index, being overweight, poor nutrition, diet, and UV exposure. So again, there's other types of diseases that we think about are also genetic and also passed down through families, such as diabetes, coronary artery disease, and colorectal cancer. But you can see from this chart here that the AMD is about 70% risk is from genetics, and these other diseases that we often think about having a genetic component are actually quite a bit less. So it really does have a strong genetic risk. I like this slide because it sort of helps explain how we can use a patient's genetic background as well as their lifestyle to determine whether or not a patient's likely to get macular degeneration. So, and I sort of liken it to playing poker, right? And I occasionally like to play poker with some of my friends. We don't really play for much money, honestly. It's more for fun than anything. But you know, you have your genes, and I like to play Texas Hold'em, so I'll use that as a reference, right? So you have your genes. So your genes are kind of the hand that you're dealt, right? So it's just the hand that you dealt, and there's really nothing you can do to affect that at all. So the genes are the hand you dealt from your parents, right? And then you, on top of that, you look at how you deal with that hand. How do you use that hand, right? If you have excessive weight, lack of physical activity, or smoking, those things are going to make that hand very difficult to play, and you might not do well, and you might end up with age-related macular degeneration. Same thing if I get some cards dealt to me and it's a very good hand and I play that hand well, right? I don't smoke, I'm not overweight, I eat healthy. My chance for winning, my chance for not getting macular degeneration is fairly good. But if I get dealt a bad hand and I live poorly, I do those things, I smoke, I'm overweight, I don't take care of myself, my chance for getting age-related macular degeneration is increased. So by knowing the hand that we're dealt and then how we use that hand, the lifestyle factors that we do, it helps figure out our chance for getting macular degeneration or for not getting macular degeneration. So that's why I feel that genetic testing, knowing where we started, can be very helpful for patients to predict outcomes. They've done studies, and what they found is genetic factors and risk are more than additive. What does that mean, right? Well, they did a study and they found that former smokers are about 1.3 times, 1.29 times more likely to get macular degeneration than someone who's never smoked in their life. If you're a current smoker, still, that risk is about 2.4 times. Other studies have that number a little bit higher, but 2.4 times in this particular study. If you're a non-smoker and you have this complement factor H, Y402H, and that particular little change in the genetic profile was found in many studies to be the number one factor determining whether or not someone gets macular degeneration, right? This one little change in the genetic profile, CFH, Y402H. What they determined is if you're a non-smoker and you have this high-risk gene, you're about 7.6 times more likely to get macular degeneration. However, if you're a current smoker and you have that high-risk gene, you're about 34 times more likely to get macular degeneration than someone who doesn't smoke and doesn't have that gene. So again, you can see how your genetic profile as well as your behaviors can really help, can interact, work together, and figure out a patient's chance for getting macular degeneration. So when it comes to macular degeneration, there are actually two commercially available genetic tests currently available for macular degeneration. There's one by this company called Arctic DX, and their test is called Macular Risk, and I'll talk about that briefly. And then there's a second company, it's a little bit newer out there, and I am doing a little bit of work with this company because I think it's a great idea. It's called Visible Genomics. And Visible Genomics has two separate tests. They have a test called the progression test, and they have a test called the lifetime risk test. And I'll explain the difference in a moment. But by way of background, what is genetic testing, right? And we've probably all heard the term genetic testing, but genetic testing is a type of medical test that identifies changes in a patient's chromosomes or genes. And by looking at changes in chromosomes and genes, it can help rule out a suspected genetic condition, right? It can also help determine a person's chance of developing or passing on a genetic disorder, such as macular degeneration. It may also be useful in determining the best treatment options. We'll talk about that in a second. And currently, there's more than 1,000 genetic tests currently in use for a wide array of different medical conditions. So obviously we're talking about macular degeneration, but there's other diseases as well that they use genetic testing to either help with the progression, determine how serious the condition might be, or to determine what treatment might be best suited for a particular patient. So some of those things that we're currently doing genetic testing for: breast and ovarian cancer, celiac disease, bipolar disorder. There's actually a lot of interesting research going on right now looking at bipolar disorder and other type of mental health disorders. And it seems that there is a strong genetic predisposition for some of these mental health ailments. And it sort of makes sense because sometimes, unfortunately, you do see that this does run in families. Parkinson's disease, obesity, and like we're talking about today, macular degeneration. So all of these things do have genetic testings that they use in various ways to guide treatment or help with a diagnosis. And in eye care, we just started genetic testing within the last 5 or 7 years or something like that. But other fields have been doing genetic testing for a little bit longer. And here's a picture of Katie Couric here. And Katie Couric's first husband passed away from colorectal cancer. And colorectal cancer, they do a lot of genetic testing in colorectal cancer to find patients at higher risk for colorectal cancer, as well as to find patients to help guide treatment once they're diagnosed. And then Angelina Jolie, she did some genetic testing, was found to be at a very high risk for developing breast cancer. So she did some things to decrease her likelihood for getting it. So this is not a thing that's only in eye care, it's in other fields as well, which is nice because it kind of gets the conversation going with our patients, and we can explain to our patients, about genetic testing, and they're a little more familiar with it when we see it in other fields as well. I alluded to treatment-wise, and there's this kind of growing field called pharmacogenomics, and what that means is they actually use genetics to help guide treatment. And in other medical fields, they use this to help determine which drug is most appropriate, which drug might produce less side effects, and then they can offer the drug that might work best. So as an example, in colorectal cancer, if a patient's diagnosed with colorectal cancer, very often one of the first things they'll do is genetic testing. And then they use that genetic testing to help guide treatment, because they know through years of studies and research that certain patients might respond better to certain treatments based on their specific genetic background. As far as AMD goes, we're not quite there yet. They are looking at some of these studies for genetics and treatments. Some of the anti-VEGF agents like Lucentis and Eylea, that these are agents that are injected into the eye to help with wet macular degeneration. They're trying to determine if a patient's genes, their genetic profile, might determine who responds better to which type of treatment. So far, the results have been a little bit inconclusive, but it's very, very interesting. And I hope that someday this might be the standard of care, that before we start treating a patient with macular degeneration, we genetically profile them, and that helps us determine which treatment is better. And the advantage of that is it could save time and money, and also really, in our case, patients' vision, because you know what your best chance for success is before you start treating the patient. So, in a way, in medicine, in a way, we do trial and error. In a way, we know that this medication generally works well on most of our patients, so we're going to try it on you, hoping that it works. But we don't really know if it's going to work for you until we try it. But perhaps in the future, we can use genetics to help narrow that playing field down, so we know, well, patients with your genetic profile, generally respond very well to this and not this, so we're going to start there. So rather than trying multiple medications, it might help us zone in on the most appropriate medication the first time. So as I mentioned, there's two commercially available, There's two commercially available companies right now that are doing genetic testing. and the first company is called Arctic DX, and they have a test called the Macular Risk NXG, and it looks at 15 what they call SNPs, and SNPs are individual changes in the genetic profile, so little changes in the DNA backbone. So it looks at 15 of these, as well as smoking, body mass index, age, and AMD status, to determine patients that already have the earliest levels of macular degeneration. And it looks at those patients and helps determine which of those patients may progress to advanced macular degeneration and subsequent vision loss in 2, 5, or 10 years. So this is kind of how their report looks. And what they do is they break down patients into 5 categories based on their risk. Category 1 is the lowest risk. Category 5 is the highest risk. And this is an example, unfortunately, of a patient that falls into the highest risk. The good news is that probably less than 5%, probably around 3% or so, of patients would fall into that very high risk category. A lot of the patients are a little bit less than that, which is good news. But in this particular example, this patient is in the highest risk. So what that tells us is that this patient has a 2-year risk of 16%, a 5-year risk of 39%, and a 10-year risk of 67% of conversion to geographic atrophy or wet macular degeneration based on both their genetic and non-genetic features. So by doing this, we can kind of stratify our patients into risk categories so we know where they fall on the spectrum of risk. And then we can use that information to tailor our exams and tailor our education towards those patients. I'll talk about that in a second again. There's a second company now that's out there. It's called Visible Genomics, and they have actually 2 separate tests for macular degeneration. They have one called the AMD progression risk testing, and this is similar to the one that Arctic does as well. But this is for people more than 55 with or without AMD findings, or in my mind, more importantly, for people less than 55 with AMD findings. I'm sorry, I said that incorrectly. For people less than 55 with AMD findings, or people 55 with or without AMD findings. So, and in my mind, this test is probably even better for patients that have the earliest signs of macular degeneration. So they'll go to the eye doctor. The eye doctor will see the very earliest signs of macular degeneration. And then we can do this test on a patient with early macular degeneration, again, to assess a patient's risk of progression to advanced macular degeneration within 2, 5, and 10, very similar to Arctic DX. But this particular test goes out 20 and 30 years, which I feel is important because patients are living longer. They're living to be older now. So this test goes out a little bit further. And again, we can use this information to come up with a strategic plan to hopefully delay their getting advanced macular degeneration. And there's different ways, we can do that. We can use vitamins, increase surveillance, home monitoring of macular degeneration. So there's different ways that we can do this in order to help take better care of our patients. There's also a second test they do, which I think is very interesting. It's called the lifetime AMD risk testing. And this is geared at patients 55 and younger without AMD findings. And this assesses a patient's lifetime risk of developing advanced AMD, whether it be, geographic atrophy or choroidal neovascular membrane, which is the wet form. And this will allow preventative lifestyle changes at a younger age. So the way I see this one working is if you have a patient, or if you yourself have macular degeneration, perhaps you're in your, 70s or 60s, 70s, you have some early signs of macular degeneration. Well, your son, who's in his 40s, would like to know, geez, what's my lifetime chance of getting macular degeneration like my dad or my mom has? So you could do this test on a patient. It tells them their lifetime risk. And again, to me, that's powerful information because the patient can then use that information to delay the onset of the disease, hopefully with lifestyle changes, lifestyle modification, and other interventions. So that's what we're going to talk about a little bit more. And this is from the Visible Genomics. Again, it's based on the latest in AMD genetic research, and they look at both genetic and non-genetic markers, very similar to what Arctic DX does. And they use this information in order to come up with a risk profile for our patients. And this is their report. It's a little bit different, but here you can see in this patient example, this patient has been determined to be in the high risk category. And if you see their risk in 2, 5, 10, 20, and 30 years, in 2 years, their chance of getting advanced macular degeneration is 5%, 5 years, 25%, 10 years, 50%, 20 years, 70%, and 30 years, 75%. So again, we can use that information in order to counsel our patients. So the way that I feel that we can use this information, right, is if we do genetic testing on a patient and we find that the patient is at higher risk, that's a patient that I'm going to want to see more frequently. I'm going to do increased surveillance on that patient, right? So if I know you're in a high risk category, right, rather than seeing you once a year or once every 6 months, maybe I want to see you every 3 or 4 months, depending on your risk and other factors as well. So sooner or more frequent appointments, depending on your risk, and more diligent home monitoring. Now there's some new technology in place. It's called the 4C Home, and I believe Dr. Blemker will talk about that later. But it's a way that patients can check their dry macular degeneration home to make sure it's not advancing to the more severe wet stage. So again, if a patient is at high risk, that's a patient that might really benefit from some home monitoring. More diligence with modifiable risk factors. And probably all of us shouldn't smoke. All of us should eat healthy, right? We all should. But if a doctor, if a doctor were to tell me, I did this test on you, you're at really high risk for something bad happening. You really need to watch your diet or stop smoking or whatever. It might really speak a little bit stronger when we have the background to show that. And I always say it's kind of like, I went to the doctor a couple of years ago and they checked my cholesterol levels and it wasn't high, but it was kind of, edging towards high. And the guy said, hey, your cholesterol is a little bit high. You should really think about, doing something about it. And I tried, right? I'm not perfect. None of us are, but I tried to eat a little bit healthier. I tried to cut some of the things out of my diet that I thought might be bad for my cholesterol. And it actually has done a little bit better. So it's more of a preventative approach rather than a reactive approach, right? What can I do before things get really bad rather than waiting for things to get really bad? Consider earlier vitamin supplementation. I'll talk just briefly about vitamin supplementation, but studies have shown us that certain vitamins can help slow down the progression of macular degeneration. So if a patient, is at very high risk, I'm going to really discuss with that patient the importance of using these vitamins. And perhaps I might do them earlier than I would based on their clinical picture if their genetic background tells me they're at higher risk. A correct vitamin supplementation. There's some research out there. It's a little bit controversial. There's some literature out there that shows that certain patients might respond to certain vitamins better than other vitamins based on their genetic background, based on the genetic profile. So some studies have shown this to be true. Some studies have not shown it to be true. So in the optometric and ophthalmic literature, there's some debate about whether or not we should be doing genetic testing in order to help guide our vitamin supplements. But it is out there. Some doctors, believe in that. And I think that's fine. Some doctors don't believe in it. And I think that's fine as well, because the jury is really out in regards to this. And then potential treatments. And, one of the thoughts is if we know that the genes that help create or put a patient at risk for macular degeneration, perhaps we can treat patients on a genetic level to help fix their macular degeneration. And, it's really within the last couple of years, there's been huge advancements in gene therapies for a variety of diseases. There's one out there for certain inherited retinal diseases now called Luxturna, I believe it's called. It's been out for a couple of years now, but and in other fields as well, they're also starting to do genetic treatment now that we have more information about genetic testing. There's a couple different companies that are looking at genetic treatment for macular degeneration. They're all currently in studies, and none of which are available, to patients yet, unless you're enrolled in a specific study. And I would say, if you're interested in looking into, studies like this, most like university centers would be the types of places that have access to studies, whether it's on genetic treatment or other treatments for macular degeneration. Like I live out here in California, like UCLA as an example, or USC. Those are type of places that do a lot of these studies for macular degeneration. So if it's something that you're, interested in seeing, could you be a participant in this? Very often these large university settings do these studies. Keep in mind that a lot of these studies have very strict guidelines about who they can enroll and who they can't enroll. So, if you look into it, don't be upset if they say that you're not a good candidate for this particular study, because they have very strict parameters sometimes who can get into these studies. I just want as an aside. But essentially what they do, they're starting with some genetic treatment. There's a couple companies, you can see them down there on the bottom. And they're using viral vectors to introduce an anti-VEGF encoding transgene to allow the eye to begin to secrete anti-VEGF. So essentially what it does is it transforms the eye into a biofactory, and it produces its own anti-VEGF supply. So now if a patient has wet macular degeneration, they get serial anti-VEGF injections. And unfortunately, perhaps, some of you may be going through that now, but you have to keep getting injections of, an anti-VEGF agent anywhere from, as soon as 1 month to a couple months, in order to maintain your vision and the status of your eye. Well, these companies are looking at actually doing something so your eye produces that solution itself, rather than having to get injections. So it's really, really pretty cool. Again, the studies are sort of, still in the early stages. It's not available for commercial use yet. But it's something, if everything goes well, perhaps could be. I was talking to a colleague of mine who's involved in some of these studies. And unfortunately, he said he feels that it's at least 5 years at minimum till we know 100% whether or not these are viable treatment options for patients. I mentioned, a little bit earlier that there are some vitamins out there that have been shown in studies to slow down the progression of macular degeneration. And the results showed that about a 25% risk reduction in developing advanced macular degeneration in patients with intermediate AMD or worse that took certain vitamins. So they did some early studies back in the early 2000s, and they showed that this certain vitamin supplement would help slow down the progression of disease in certain patients. So after this study came out, many of us, myself included, started to recommend vitamin supplements for patients with in the study sort of showed it was most beneficial in patients with moderate, intermediate, or worse macular degeneration, meaning if you had very early macular degeneration, the studies were somewhat inconclusive whether or not it was helpful. But once you get to that moderate stage, it showed quite clearly that it slowed down the progression by about 50%, by about 25%, excuse me. So as such, I recommend it for many of my patients with macular degeneration that fall within certain parameters. They did a study a couple years later called the AREDS-2 study. And this looked at, and this ended in 2008, and the results came out though in 2013. So we're coming on, 8, 9 years now, 8 years anyway. And they looked at the effect of lutein, zeaxanthin, and omega-3s on macular degeneration, because these were things that were shown in smaller studies to be helpful for macular degeneration, its prevention, and that sort of thing. So now we wanted to do a large study on it. Beta carotene was shown in the initial studies, vitamin studies, to be helpful, but it had some unwarranted side effects. So we wanted to see if we could get rid of beta carotene and still have a good product, and also the effect of reducing zinc on macular degeneration. Some people feel that the excess zinc is not good for us. They did a study, and the night that the AREDS 2 study came out, Emily Chu, who's a lead investigator of the study, she came out with a presentation, went over all the results, and this was her closing slide. And this is what they recommended after the second study that patients take in order to help slow down the progression of macular degeneration. Vitamin C, vitamin E, and you can see the amounts there. Lutein 10 milligrams and zeaxanthin 2 milligrams. So if you're going to start taking a product for your macular degeneration, I really recommend that you find a product that has lutein and zeaxanthin. And most commercially available products have that 10 milligrams of lutein and 2 milligrams of zeaxanthin, because that's what was looked at in this particular study. And what they found was if we use lutein and zeaxanthin but got rid of the beta carotene, the product was now safer because we didn't have to worry about the untoward side effects of beta carotene, and it actually worked a little bit better as well. Zinc, they were recommended to stay the same, and then copper, they recommended the same as the original study. And then omega-3 fatty acids, which many smaller studies seem to point to the fact that it was helpful. And this particular study did not show. So I really don't recommend omega-3 fatty acids for my patients with macular degeneration unless there's specific reasons. And there's a bunch of products out there, that you can use for your macular degeneration. What I would encourage you to do, if you're interested in if you're not on some vitamins and you're interested, I would encourage you to schedule an appointment with your eye care provider, and they can talk to you about the differences in the products and which one or ones they feel might be best in your particular case. There are some differences in them. So it's best to talk to a professional about what to take in your specific circumstance, rather than just going out to the drugstore perhaps and purchasing one that might not be the best one for you. So that's what I encourage you to do. I just want to talk about a couple other studies that also show the importance of other things we can do as patients to help slow down the progression. And again, my whole background, my reason for doing this is, again, these are things, if you were to get genetically tested and found to be, in high risk, these are things you should definitely think about. But really, any patient with macular degeneration or any patient with a family history of macular degeneration, these are some things that I think you can think about doing. And, some of them are rather hard to do. Some of them might be easy to do. And some of them, maybe you can't do 100%, right? But maybe you can do small changes, and even small changes can sometimes add up to a big change. So, I encourage you to think about, how you can use some of this information in your daily life to perhaps make a positive impact on your macular degeneration. So diet plays a big role in macular degeneration. There was a 2018 study, and there was actually just a recent study. I didn't have a chance to include it, but a recent study confirmed these results as well. But what they showed was they looked at a bunch of patients, almost over 4,000 patients, and what they showed was adherence to a Mediterranean diet reduced the risk of advanced macular degeneration by about 41% in patients that had early macular degeneration. So this sort of supports the role of a diet rich in fruits, vegetables, legumes, fish, low in red meat and low in processed food, being helpful for macular degeneration. And that kind of makes sense, right? Like we know from other studies that fish is probably good for macular degeneration, and processed food is not good for macular degeneration, nor is it really good for anything, quite frankly. There was another earlier study in 2016, and this specifically looked at fish consumption. So what they showed in this was fish consumption reduced the risk of both early and late macular degeneration. And it worked in patients less than 10 years as well as patients after 10 years. So the effect was short as well as long lasting. Dark meat fish, especially tuna, was associated with reduced risk of AMD. And there was a linear association between the dose of fish consumption and risk of AMD. So in other words, the more fish they ate, the less their risk of AMD was. The less fish they ate, the more their risk for macular degeneration. So it really went hand in hand. So things like this sort of show us the importance of eating healthy and perhaps adding fish into our diet. Um, there's another study here looking sort of at the same thing. 18% reduced risk for total macular degeneration with increased fish intake, both early and late macular degeneration. 20% increase for total AMD with increased alcohol consumption. So again, everything in moderation, right? A glass of wine or two is not going to kill you, but you want to keep it within reasonable levels. Increased risk for meat consumption for early macular degeneration. This particular study didn't show a huge impact in fruits and vegetables, nuts, grain, and dairy, but other studies have. Again, another study, determined a diet of 200 grams per day of vegetable, fruit 2 times a day, and fish 2 times per week is associated with significantly reduced risk of macular degeneration. But only 3.7% of patients adhered to this specific diet. So again, it's very hard to adhere to some of these things. I myself am not, I used to not be a big fish fan. When I started to learn more about macular degeneration, I've tried to institute fish, at least, once or twice a week. I've tried to, have fish and decrease my amount of red meat, right? This is another study. Red meat more than 10 times a week had an additional 47% risk of developing macular degeneration versus those who ate red meat 5 times or less. And chicken, especially white meat chicken, had a 3.5 times a week, had a 60% chance, less risk of macular degeneration versus those who ate it 1.5 times a week. So again, if you could perhaps substitute red meat, once or twice a week with either chicken or fish, again, this is going to have a positive, impact. And certainly, as I said, it's hard to do all of this, but even small changes can sometimes make a big deal. Exercise, right? Exercise has been shown in other studies to be helpful for macular degeneration as well. This is a study from 2017. Physical activity is associated with lower odds of early and late macular degeneration in a specifically white population. And it suggested that even a small amount of physical activity, as little as 3 hours per week, may be beneficial. And in this particular study, when they say exercise, they weren't talking about going to the gym, right? They weren't talking about lifting weights or, going on a Stairmaster. They were really talking about walking. It's something as simple as walking, every day can really be beneficial in patients with macular degeneration. There was one study, this is it right here, that showed 30% lower rates of wet macular degeneration with patients who walk 12 or more blocks 3 times a week. So again, 12 blocks is not a huge amount, but even if you can't do 12 blocks, start out at 3 or 4 blocks and see if you can increase that over time. Because again, we know that exercise can help prevent macular degeneration and decrease the risk for late macular degeneration, 70% in this particular study. Smoking, I talked about smoking. I'm really very adamant that I talk to all my patients with macular degeneration or patients at risk for macular degeneration, whether it's family history or other issues. Excuse me. I really talk to them about smoking and macular degeneration because smoking really has been shown in multiple studies to be the #1 modifiable risk factor for getting macular degeneration as well as its progression. Studies show it increases your risk for macular degeneration anywhere from 2.5 up to almost 5 times. So by simply stop smoking, it can really go a long way. And I know it's difficult. I know, my dad was a smoker. He smoked practically till the day he died. He tried to quit many times and he had a very, very hard time quitting. I know it's very addictive. But, again, it's just something to think about that we can do to better our health. One study showed that 90% of patients with macular degeneration were not advised to quit smoking by their eye care provider. So that's why I try to encourage my fellow optometrists and other eye care providers that we really need to discuss this with our patients. And less than 50%, I left off the percent sign, I'm sorry, of smokers knew, less than 50% of smokers knew that smoking may contribute to their macular degeneration and eventual blindness. So again, I think if you're a smoker, it's really, you should really think about, curtailing your smoking, decreasing your smoking to start out, and hopefully eventually stopping altogether. By the way, most of the studies of smoking really looked at cigarette smoking. They didn't look much at pipe or cigar smoking. There was one small study that showed that cigar smoking was associated with an increased risk as well. We probably know that no smoking is good for you, but cigarette smoking is probably the worst. This was a Nurses Health study, 2.5-fold increase in AMD in current smokers, a 2-fold increase for past smokers. And it's interesting because they looked at patients who quit smoking, and they showed that they really didn't start to have that decreased risk until 15 years after cessation. So, it takes a while to get the positive effect. Yeah, and 30% of all AMD patients is related directly to smoking. A Blue Mountain Eye study. This is probably one of the bigger studies, longitudinal studies done in eye care. They looked at a bunch of stuff. But what they showed was current smokers had a 4-fold increase in late AMD compared with people who never smoked, and former smokers had a 3-fold increase in late AMD, especially geographic atrophy, and 20% of all cases of blindness related to smoking in this particular study. This is a newer study that actually looked specifically at smoking and treatment, and what they found in macular degeneration and wet macular degeneration in the whole 9 yards. What they show is current smokers have a 7-fold greater increase for neovascular wet macular degeneration versus non-smokers. And it's worse. In these patients who smoke, their wet macular degeneration is worse. It tends to bleed more and decrease their vision more rapidly. Current smokers were 6.2 years younger than non-smokers needing treatment. So patients who smoked needed treatment earlier than those patients who didn't smoke. And then they also found that patients who smoke while undergoing treatment experience inferior results at 1 and 2 years versus patients who didn't smoke. So again, it just goes to show the dangers of smoking. Obesity, being overweight. There's certain studies that show that being overweight is probably the second biggest modifiable risk factor for macular degeneration, second to smoking. And this particular study done years ago, it showed an increase for advanced AMD with a body mass index above 25. Even worse if your body mass index is greater than 30. And body mass index is a formula that looks at your height and your weight and comes up with a number. You can Google, if you're interested, body mass index, and there's charts. And you can find your height on one axis, your weight on the other axis, and it will tell you your body mass index. In a perfect world, we want our patient's body mass index to be less than 25 in a perfect world, but less than 30 for sure. And again, this study said higher waist-hip ratio also increased risk for progression. So patients that are very hippie, right? That's where we sometimes store a lot of our fat. That is also very bad as well. And 25% reduction for patients with vigorous activity 3 times a week. Other studies have been less conclusive. UV, again, I mentioned it earlier, UV, current sunlight exposure show no associated with early or late macular degeneration, but past sunlight exposure was associated with early macular degeneration. So that's why it's probably more important when we're younger that we protect ourselves from UV light more so than we're older. In a way, once we're older, the damage has sort of already been done through years and years. So what I would suggest, if you have macular degeneration, you have younger family members that don't have macular degeneration, as when they're younger, 20s, 30s, 40s, that's really the time to start thinking about proper UV protection to prevent the damage way down the road. Beaver Dam study, again, it showed that patients who spent a lot of time in the sun while in their teens were a higher risk of developing macular degeneration later in life. And people who reported 10 or more severe sunburns during the youth versus 1 or no burn were at higher risk. And it's interesting, I have an old friend of mine who's a dermatologist, and in dermatology, they find very similar things. If you've had sunburns when you were younger, in your teens and into your 20s, that puts you at higher risk for skin cancer later in life. So very often how we treat our bodies when we're young when we think we're invincible, unfortunately, can play a role later in life. So really, kind of in a nutshell, how do I use this information to talk to my patients with macular degeneration? I really recommend all my patients with macular degeneration. I really recommend they don't smoke because, as I mentioned, number one modifiable risk factor. Exercise regularly if they're able to. And again, when I say exercise, I'm not talking about going to the gym, going on a treadmill, going on a Stairmaster. I'm talking about something as simple as going out for a walk, because studies have shown that even as little as walking 12 blocks 3 times a week can be beneficial for macular degeneration. Keep other medical conditions under control. We didn't really talk about that today, but concurrent hypertension, concurrent diabetes, concurrent other medical conditions can make your macular degeneration worse. So you want to make sure that your other medical conditions are under control. Maintain a healthy weight. We talked about how increased body mass index is a risk factor for macular degeneration. Eat a diet high in fruits, vegetables, and fish. Limit intake of red meat and foods high in fat. And again, I used to not be a big salmon fan, big fish fan, but I started to look at different ways to cook salmon and different recipes for salmon and other fish. And I've experimented a little bit and I found some ways that really, work for me. So, think about that. Protect your eyes from sunlight with UV protection and sunglasses, especially when we're younger, but also when we're older, but especially when you're younger. Take supplements as prescribed by your doctor. Hopefully you've had an opportunity to talk with an eye care professional and whether or not these supplements are appropriate in your specific situation. And then follow up with your doctor as recommended. If they recommend you see them every 4 months, 6 months, a year, whatever they recommend, make sure you try to adhere to that. And then specifically for today, consider genetic testing. Now, I'll tell you, not every eye care provider, whether an optometrist like myself or an ophthalmologist, not all of them are doing genetic testing currently. It's sort of an emerging field. So you might have to search for a doctor in your area that does genetic testing and can guide you as to how to use that information. But I do like the idea of genetic testing. I think we can use that information to tailor a program specific to a patient's individual risk, whether that be increased surveillance, better diligence with lifestyle changes, or vitamin supplementation. So that's the end of my presentation. I'm happy to answer any questions. I'm going to see if I can get over to this question thing. Thank you very much for listening today. Let me see if I can get over to the question and answers, and I'll try to answer some questions here, okay? And if you have any other questions, please type them into the question and answer. I'll try to get to as many as I can. Someone says, I use Costco brand vitamins called OcuSight. Is this comparable to AREDS 2 vitamins? I have dry macular degeneration. Thank you. You're welcome. So the answer is probably. There's a lot of different vitamins out there. It's really hard for me to know, every single one out there. But Costco has some brands that are very good, and they have one brand that's not. So what you want to do is just look at the ingredients, and you want to make sure that it has lutein, 10 milligrams, zeaxanthin, 2 milligrams, and no beta carotene. So those are the things you really want to make sure it has. If it has those, if it has lutein and zeaxanthin and no beta carotene, it's probably fine. Next question, can you change your genetics? Unfortunately, as far as we know, no, right? Just like, at least not currently, right? And, maybe in the future they will be able to, but currently I always tell people, just like you can't change who your parents are, right? You can't change your family history. As far as we know, you cannot change your genetics. So the goal is to use your genetics to help guide what you do with your genetics, help guide your lifestyle, and that would be the positive change you can make. No one in my family has macular degeneration. I was diagnosed with it. Should I tell my children to get tested? And I would say yes. I work at a VA hospital, so I sort of specialize in older geriatric patients. That's sort of my my patient population, and also at the VA, I can't see people who have not served in the military. But very often, if I have an older patient, say in their 70s or whatever, with macular degeneration, I do tell them, hey, do you have kids? And they should at least get an eye exam, right? Just a comprehensive eye exam to see if they have any early signs of macular degeneration, so that perhaps they can have some of these lifestyle changes instituted. Where can I get the test done? What are the costs? Does insurance cover this test? That's a very complicated question. I hate to be vague, but as I mentioned, not all doctors are doing this, are doing the genetic testing. Insurance sometimes covers it in certain circumstances and sometimes doesn't. And it really just depends on what type of insurance you have. The situation I work at, I don't deal with a lot of insurances, so I don't have a lot of experience with that. I believe if you go to the Arctic DX website, I think they used to, I haven't looked lately and I do apologize. They used to have somewhere they could help you find a doctor who does the genetic testing. I had the test done, and if it comes back bad, what can be done? Well, I think we discussed, I think we discussed that a little bit, right? And then we can institute some of those lifestyle changes: no smoking, lose weight, don't smoke, and that sort of thing. I was told the amount of zinc in the AREDS vitamins can cause more vision problems. Is this true? I alluded to that just a little bit, that certain studies have shown patients with certain genetic profiles respond better or worse to certain products. And one of those things is, if you have a certain genetic profile, one study showed that high levels of zinc might not be beneficial and might actually be harmful. But again, not everyone agrees in that. So again, if that's something you're interested in, and obviously I can't discuss your particular case, but if that's something you're interested in, I would encourage you to get genetic testing, and that can help guide whether or not you fall into that category that zinc might be not good for in your particular case. What can I do if I don't like fish? Well, just suck it up and eat the fish. No, I'm kidding. And for years I didn't like fish, either. Omega-3, omega-3s, or our omega-3s. Again, in the AREDS 2 study, they didn't show if omega-3s were horribly helpful. But if you really don't like fish, I think you can get some benefit from omega-3s. Omega-3s, there's two kinds of omega-3s. It's called DHA, and I could tell you what it stands for, but I usually forget, and EPA. DHA and EPA, and those are the better types of omega-3s. So if you really don't like fish, and you want to get some protective benefit, I would suggest maybe considering taking 1,000 milligrams of omega-3s, and of those 1,000 milligrams, you want the majority to be DHA and EPA. But again, I would run that past your eye care provider and make sure that that's appropriate in your particular case. I smoked in my early years, as my parents did. Of course, I've stopped many years ago. It's just, I know, is there anything else to be done? Well, again, you stopped, so that's already a great start, right? You're reducing your odds by stopping. And then, again, I would check with your eye care provider whether or not the vitamins would help in your particular situation or not. And other things like, exercise, eating healthy, and that sort of thing as well. I have diabetes and was just told I have macular degeneration. Did my diabetes cause this? Probably not. They've done some studies and they've tried to determine, is diabetes a risk factor for macular degeneration? And it's really very, very inconclusive. So more than likely, these are two totally separate things that unfortunately, you have and you have to deal with. Unfortunately, there's probably no correlation. But both diabetes and macular degeneration can cause adverse damage to your eyes. So I would suggest that you follow up closely with your eye care provider and make sure that both of these issues are getting attention. what question should I be asking my doctor? Both my parents had macular degeneration. Yeah, I mean, I would ask him, do I have any of the early signs of macular degeneration? On your routine exam, do you find this? Are there any um, additional information that any additional testing we should do, or is there any information you can give me to help reduce my risk for getting macular degeneration? And we talked about those things: diet, exercise, no smoking, and that sort of thing. And then I would think about, um, I would think about genetic testing to see what your risk is, and then you can use that information in a positive way to make positive changes in your lifestyle. Um, do you have any recommendations of non-animal food sources with benefits similar to fish? Geez, that's an excellent question. That's an excellent question. Unfortunately, I don't. I mean, other than taking, like I was speaking to that other gentleman, omega-3s, and they do have some vegan-based omega-3s, right? But there's not a lot of fruits and vegetables that have a lot of omega-3s that I'm familiar with. And if there are, I apologize. It's just not something I know of. Yeah, so unfortunately, I think if you don't like fish, you might have to think about taking a supplement to get those omega-3s. I'm 69, have wet AMD 5 years. I'm sorry to hear that. And the history of AMD in my extended family. Should I encourage my children in their 30s to get genetic testing? At what age? I mean, I would, because I just look at it this way, right? If my parents had macular degeneration, or even if they had, let's change it a little bit, even if they had, like prostate cancer, right? I would want to know what my PSA is. I would want to know what my factors are that might put me at risk for also getting this ailment. So I think it would make sense to encourage your family to at least think about genetic testing, certainly to get a comprehensive eye exam and discuss it with their eye care provider, whether or not they feel it's appropriate. And as to what age, I think, better late than never, right? In their 30s or 40s, I think is appropriate. To have genetic testing, especially if you have a family history. If you don't have a family history, maybe you wait a little bit longer, but with a family history, I think it makes sense to consider getting testing, in your 30s or 40s for sure. At what age should you consider having genetic testing? I think we were just talking about that, so I think we answered that. 83 years old, had early AMD a couple of years ago, and in the same eye clinic for at least 40 years. I have there are some highly rated AMD specialists, so I seek an appointment for one of these since I have this diagnosis. That's an excellent question, Kirk, and it's hard to answer. I would just say that if you feel that you're getting good care and you're getting and you're getting good care and you're getting the answers to your questions answered, and some of the stuff I've told you today you've heard before, and they've talked to you about vitamins and that sort of thing, I think you're probably fine. Now, if you feel you're not getting an answer to your question and you don't feel that they're doing appropriate things, then I would think about getting a second opinion. One of the problems I would just tell you is that when you say an AMD specialist, a lot of these specialists, are specialists treating macular degeneration, treating the wet form of macular degeneration. So if you have the dry form, there might not be much more they can offer than what what your regular eye doctor is already offering you. But as long as you feel you're getting good care, you're getting answers to your questions, I wouldn't necessarily say you need to see a specialist. Do you need a dilated eye exam? Some offices offer non-dilation. So there are alternatives to dilation. They can do certain photos and stuff like that. And I would tell you that it's okay as an adjunct to a dilation, but the best way to really look in the eye and the best way to determine eye disease really is through a dilated eye exam. So I think that non-dilated things like photos and other things are a nice accoutrement, but they don't take the place of a dilated eye exam. So I would recommend a dilated eye exam. Should I use AREDS 2 with or without zinc? One with. So again, we don't know the answer to zinc unless you unless you get genetically tested. And again, not all providers believe in that specific use for genetic testing. But I would say if you're concerned about zinc or no zinc, then I would get genetically tested, and that will help guide you and your provider as to what is best to use. My mother had both wet and dry AMD. There used to be 3 or 4 types of A-red vitamins 10 years ago when she was under my care. Now I only see one on the shelves. Can you only assess why? Well, so I was kind of talking earlier, there was the original A-RED study, and then there was the A-REDS 2 study. And after the A-REDS 2 study came out, we feel now that the products in the A-REDS 2 study, specifically the lutein and zeaxanthine, are better than what was in the A-REDS products that had beta carotene. So at this point, I don't recommend any product with beta carotene. I instead recommend patients take stuff with lutein and zeaxanthine. So if you go, you want to make sure that it says AREDS 2, right? Vitamins. And probably, perhaps in your area, the AREDS ones are going away, and not as many people perhaps are making the AREDS 2. But you want to make sure it says AREDS 2. Those are the best. See, I had a macular risk test. Excellent. And it predicts I had a 50% chance of a wet AMD. Would it be more beneficial to get the visible genomics test? That's a good answer. I mean, it does go out a little bit further. It goes out to, 20 or 30 years. And depending on your, age and circumstance, I'm not sure that would be, helpful information for you or not. But I just applaud you for getting for getting genetic testing, and hopefully, you can use that to your benefit. Is myopic macular degeneration a result of a genetic defect? No one else in my family has this diagnosis. That's interesting. My answer to this is probably, right? There probably is, and that's not really my field of expertise, if you will. I don't know if I'm an expert in anything, quite frankly, but my understanding is that there is probably a genetic component to myopia as well as myopic macular degeneration. But to my knowledge, I don't know if anyone's doing genetic testing for that at this time, because again, it's a little bit out of my field. Wet AMD in one eye, 59 years old. Are the chances high that I would get it in the other eye? It's a chance you will get it in your other eye, right? High is hard to say, right? But there is a chance. So you do have to be a little more diligent about some of these risk factors we talked about, and you have to be diligent about seeing your eye care provider, more frequently. Also, I would suggest maybe getting genetic testing. That might give you a better idea of your chance for getting macular degeneration in the other eye. And then I would also consider home monitoring for your good eye, because should you develop wet macular degeneration in the other eye, the sooner it's detected, the sooner you get treatment, the sooner you'll do in the long run. So there are chances that you would get it in the other eye. I wouldn't necessarily say high, but you do need to keep that in mind and do some things to help minimize those chances. How is the succession of genetics? Parents, children, or just family? I have AMD. My parents perished young in the war. 2 my cousins had this illness. Are my children at risk? How is the succession of genetics? Parents, children, or just family? I'm not 100% sure I understand your question, but I mean, genetics runs in families, right? And studies have shown in the past that if your parents or a first-degree relative have macular degeneration, your chance of getting macular degeneration is increased. So if you're not sure of your parents' history, right, through whatever the circumstance may be, then I think that then you would use the rest of your family history, brothers, sisters, and that sort of thing, to kind of get an idea as well. But genetic testing would help answer that question, even if you don't know your family history. Dry AMD, my cholesterol is slightly high. Will taking statins to lower this help with AMD? That's a really good question. There have been a couple studies that have looked at statin use and macular degeneration, and they've been very inconclusive. There was one study, I believe it was out of Harvard, that looked at like 24 patients, a very small number of patients, that seemed to show that patients on statins um, had less macular degeneration than those patients not on statins. But the problem was the patients on statins also, in general, smoked less and ate better than patients not on statins. So they weren't able to tell, was it the statin or other lifestyles? Um, so we don't really know about statins, would be my answer.
Dr. Ferrucci, this was a great and inspirational presentation, and I hope to see you again soon.
Thank you. It's nice talking to everyone, and everyone have a nice day.
Okay, our next speaker is near and dear to my heart. Uh, she is Dr. Megan Blunker, who is an ocular disease residency trained optometrist. She practiced in Nashville, Tennessee for a good number of years. She now is the clinical director of clinical affairs and professional relations for Notovision, which you're going to hear is a is a device and a technology that will give you early warnings of your eyes uh, moving from dry to wet macular degeneration. It's a tremendous machine. I use it myself. For my good eye, not the one that's getting injections. It's too late for that. Uh, so I wanted to let Dr. Bumper give her presentation, and I hope you listen carefully because it's very valuable. So, Dr. Bunker, it's good to see you again.
Thank you so much for the introduction. No Television is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege. To reiterate some of the important points made in the presentation, I'd like to further discuss understanding the importance of early detection of wet AMD and how you can play a role in protecting your vision. 4C Home is FDA cleared and Medicare covered. It's prescribed by your eye care professional when you have the appropriate level of vision and appropriate stage of age-related macular degeneration. It's a form of personalized medicine with the 4C Home device used at home in between your regular eye exams, and it detects metamorphopsia or visual distortions in AMD. AMD is the leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic, meaning it doesn't resolve or go away, progressive, meaning it tends to worsen over time, type of condition. And there are two types of AMD, dry and wet. Dry AMD is the slower changing, earlier form of the disease that puts you at risk for developing the wet form of AMD. And wet AMD is the sudden change or advanced form of the disease. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In dry AMD, changes occur in the cells of the macula, and drusen, or deposits, these yellow spots that you see here on the right side of the screen in the picture, build up in this area. And these changes may induce blurry vision, such as difficulty seeing sharp details both up close and far away. Dry AMD is the slow form of the disease, with changes you may not notice over time. Most importantly, dry AMD puts you at an increased risk of progressing to wet AMD. Over time, the size and number of these drusen or deposits can increase, which increases your risk of developing the more sight-threatening form, wet AMD. Again, dry AMD can suddenly change to wet AMD without any kind of advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula, as you'll see here on the right side of the screen. These blood vessels can leak fluid, and they can sometimes bleed without any type of warning. You may not notice these changes until significant vision loss has occurred. If you convert to wet AMD, This significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion, where straight lines look wavy. You can have dark spots in your vision, or just generalized blurry vision, as you see here on the screen. Unlike dry AMD, there are effective treatments for wet AMD, but these treatments are most effective when administered early on before symptoms are noticed and before vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but they cannot restore vision that's already been lost. Once the wet disease starts, it will continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and before symptoms are even noticed. But how early is early detection? Once symptoms of visual impairment are noticed, those wavy lines or dark spots appear in your vision, then the vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision, your independence, and the ability to go about your daily life participating in activities you enjoy. So, wet AMD treatments are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps people with dry AMD detect wet AMD before you even notice that visual changes have occurred. But how does it work? Well, you take a simple daily test that checks for tiny changes in your vision. The test takes just a few minutes per eye per day. The data from each test is then sent to your eye doctor as well as the No-Tal Vision Diagnostic Clinic, the medical provider of 4C Home. If a change in test scores is detected, the diagnostic clinic alerts your doctor. Your doctor's office will then contact you directly to schedule a follow-up visit. The Amsler grid, as you see here on the left side of the screen, was developed in the 1940s and has for a long time been recommended as a simple and accessible tool that you can use from home to monitor the changes in your vision. However, by the time you notice vision distortions on this Amsler grid, significant vision loss may have already occurred. Fortunately, new technology such as the 4C Home AMD monitoring program has been developed so you can detect tiny changes before symptoms are noticed, and the system reports them to your doctor so you can receive immediate examination and treatment if necessary. Testing with 4C Home is easy. You turn the device on and look into the viewfinder to begin testing. Then a bump will briefly appear and disappear, as you can see here in the center green circle on the screen. You'll use the mouse provided to click where the bump appeared and then return to this center dot. Data from each test is then sent to the No-Tal Vision Diagnostic Clinic for evaluation and provided to your eye doctor as well. Regular at-home monitoring is like brushing your teeth. It's just a good, healthy habit you do every day to help preserve your vision. 4C Home allows you to take a proactive approach to protect your vision. A clinical partner will be with you every step of the way. After the No-Tal Vision Diagnostic Clinic receives a referral from your doctor, we'll answer any questions, verify coverage, and ship your device. Once you receive the device, the No-Tal Vision Diagnostic Clinic will walk you through setup and training. You and your doctor will continue to receive feedback from the No-Tal Vision Diagnostic Clinic. Our team will be sure to verify your insurance benefits and discuss with you prior to your acceptance of the device and prior to getting started with the program. There are low out-of-pocket costs for Medicare patients. So patients with Medicare and a secondary supplement plan could have out-of-pocket costs as low as $0 per month. Patients with Medicare and no secondary supplement plan will pay $15.06 per month once their yearly Medicare fee-for-service Part B deductible is met. Again, 4C Home is FDA cleared and Medicare covered. Your doctor will send our No-Tal Vision Diagnostic Clinic the order for you to begin the 4C Home AMD monitoring program. And appropriate candidates have a particular stage of dry AMD and a particular level of vision, which will be determined by your doctor. You'll continue to test regularly at home. If a change takes place, your doctor will be alerted and have you come in for an examination. In summary, the No-Tal Vision Diagnostic Clinic works with your doctor to remotely monitor your dry AMD, helping you retain functional vision throughout your AMD journey. I'm happy to answer any questions you might have. And thank you so much. Here's my contact information for your reference. I would love to hear from you. Great. Looks like we have some questions coming in from the Q&A here. So thank you so much for your time and attention. And let's see if I can answer some of these questions for you. The first two questions that came in are similar, so I'd like to maybe answer those at the same time. The first is, can I use this machine if my hands shake badly? The next question is, I have arthritis in my hands. Can I use this machine? I think this is a great point to bring up as far as the ability to use the 4C Home mouse that comes with it. So if you're comfortable with any type of computer system where you would rest your hand on the mouse that goes with a desktop type of computer, and you would just use your index finger to click the button, that's all that is involved with using the 4C Home device. However, if you do have a condition where your hands shake or it's very uncomfortable for you to be able to use the mouse, that might affect how you test, and that could be a concern as far as being able to learn to use the device and the device learning about you and your eyes. The nice thing about 4C Home is that it is a recommendation of a technology to help aid in the earlier detection of the conversion from the dry to the wet kind of AMD. So it's in addition to whatever your eye doctor is already recommending and whatever you're already doing in regards to monitoring your condition. So if you feel like you'd like to try it and it does not work out for you because of those reasons or any other reasons, there's no obligation to continue with it. We would simply just ask for the device back from you, and then we would stop your service at that point. So no obligation. We want to make sure that is something that is beneficial to you, and you can add that to whatever your doctor's already recommending. Great question. The next question is, are there ever false positives reported? The short answer is yes. So with any technology or any kind of diagnostic equipment, there are false positives and false negatives. Most technologies are designed this way because we want them to be specific. We don't want to be missing any kind of disease. So if you have a false positive with 4C Home, the thing to keep in mind is that it is a metamorphopsia or a distortion in your vision detector. And there are many things that can affect your age-related macular degeneration over time. This is a very dynamic process. Even the dry kind, as we said earlier, it's chronic, meaning you always have it. And unfortunately, it tends to progress over time. So it's dynamic or changing. And the 4C Home is so sensitive that it can pick up on those changes. What would happen then is the alert would be received by your prescribing physician, so your eye doctor who referred you to our no television diagnostic clinic for 4C Home would get the alert and bring you in for examination. So they would look at your eyes, they would see what, if anything, had changed. And then if you had not converted to wet AMD, they would ask you to go back home and continue testing on the device. So it's a great way for you to know that your doctor is monitoring your vision between your regular eye exams. Which type of doctor can prescribe this machine? So any licensed eye care professional, this is optometrists and ophthalmologists, can refer 4C Home patients. Can I use this machine if one eye is wet and the other is dry? Absolutely. And in fact, if your first eye has converted from the dry kind to the wet kind of AMD, you're actually a little bit higher risk in that fellow eye, your other eye, to convert from the dry to the wet kind. So absolutely, if you have that intermediate or that middle stage, the appropriate stage of age-related dry macular degeneration, and your visual acuity is of a certain level as well, then you would be a good candidate in that dry fellow eye and would benefit from 4C Home. Oh, there's a message that says, thank you. This machine was able to catch my eye starting to bleed. Outstanding. Obviously, you know, it's always bittersweet when I receive news like this, because of course we want to keep your eyes seeing well and healthy as long as possible. And that conversion from dry to wet absolutely is a life-changing experience. But if it's going to happen, I'm so glad that 4C Home was part of that plan to help detect you early. And I hope that you're getting treatments and you're able to maintain your vision. So thank you for sharing that. Is it easy to use this program? We have dedicated clinical partners in our no television diagnostic clinics. So this group of individuals, these professionals are technicians. They have had experience in clinic, and they're going to be the ones that are on the phones talking to you before, during, and after you accept using the program. So if you have questions about AMD, if you have questions about how to use 4C Home, if you have questions about what you're looking at when you're using the device, we have our team of professionals who will be with you every step of the way to help answer those questions, kind of coach you as to the best ways to test with this. There's a little bit of a learning curve with it, just like with anything else. But like I said, our team will be by your side. If you're able to sit comfortably where you can look into the viewer, and like we mentioned earlier, if you're able to use the mouse to click where you see the lines with the bumps, then you should be able to perform this test successfully. Can I get information from you or get this from you since my doctor doesn't have any information about it? So for more information, you can visit our website. That's the 4chome.com. So FORESEE, like you foresee the future, home, 4chome.com. There's a lot of information on there in general about 4C Home and about us. There is also a tab on the top right that says find a doctor. So if you'd like to find someone in your area who offers this program, that's an option for you as well. I always think it's best to just go back to whomever you are seeing currently for your eye care and talk to them about this. Tell them you attended this webinar presentation, maybe share with them the website. And then of course, our contact information is on there if you or they want to get in touch with us. Next question, is 4C Home available overseas? At this point in time, it is only available in the United States. Next question is, I think this is a great tool along with the genetic test to help protect your vision. Why aren't doctors on board? We are a small company and continuing to grow, and we are slowly but surely getting the word out, the good news out about the availability of 4C Home and how optometrists and ophthalmologists can prescribe this for their patients. So I think that we are in a great way picking up speed, and platforms such as this and partnerships with such wonderful organizations as the Macular Degeneration Association afford us the opportunity to be able to share our message with you all, with patients. And then one of my duties as well is to share this information with my colleagues, with optometrists and ophthalmologists. If you would like to learn more about us, like I said, you can go to our website. And of course, we'd love for you to share your experience with us and just share more information about us. The next question says, hello. My grandma suffers from end-stage glaucoma and end-stage myopic macular degeneration. I am so sorry to hear this. According to the latest reports, retina has deteriorated and is very weak. She's lost vision. Are there any cures about stem cells to grow in the retina? And can you please tell me the information, should she get the machine? As far as the latest clinical trials and those different types of treatments that are available, I think it's best to consult with some of our experts who have spoken on the webinars. I know that on the MDA website, on the macularhope.org, all of their board of directors and their speakers information is available there. If you'd like to reach out to them directly, or if you want to go to clinicaltrials.gov, you can always see what is available in all fields of medicine, not just ophthalmology and optometry, for clinical trials, the latest developments. As far as your grandmother, it sounds like that she may be beyond what is appropriate for the level of vision and the stage of disease for 4C Home, but definitely I would have her talk to, or if you want to talk to her eye care provider. There are different services at every stage of eye disease, early, intermediate, and advanced, and different tools and different aids to help just maximize the vision that she has left. So lots of opportunities there to help at any stage. Great. I think that's all the questions I'm showing there. I don't know if there was anything, Larry, that you'd like to add. It is always good to see you as well, albeit virtually. So thank you for your kind words earlier. And anything else you'd like me to address or anything you'd like to add?
No, I just think that early intervention of wet is what saves your sight, since that's the major culprit in vision loss. So you got a great organization. I'm not from a business standpoint, but from a patient care standpoint, and I wish you all well.
Well, thank you so much. It's a privilege to partner with you, and we love what we do. So, thank
Okay,
you.
everybody have a good day. Stay well.
Bye.